starts. I'm moving. Okay, you know that I always try to show that I come from Naples with its volcano. So we have the an innate condition of trying to be on the history and to move forward. Our university was founded almost 8 centuries ago from a German emperor, which gives the sense of our strength, even though in Naples we look like living quietly. And we have seen also in the former presentation that there has been an evolution from the old Egyptians to what we are doing today. Endoscopic neurosurgery represents some way this evolution in terms of technological advances. But we always need to remember that there is no difference between coming from below and from above if you have a proper recognition of the anatomy, which has to be studied with intensity, because it's the real basement of the whole building. This is the Aula of Morgagni in Padua. It's an old anatomic theater. We are indebted to Manfred Schabischer in Bayern, where we received one of the most important for us lessons of anatomy. And anoscopy and anatomic dissection is very, very important. Every time you perform a dissection, you learn something about the work you are going to do on the living patient. And also anatomy evolves, because the anatomy of the subject is there, but the way you learn this lesson with using computer-based models, with studying the working area where you are going to perform your operation, where when you understand the possibility of doing something where you see something, it's something we have studied in these years. We have had the need to use different instruments than before, with endoscopes that have been evolving. We had not a good relationship with the 3D endoscope. In our experience, has not been successful at all. While the 4K resolution of some new endoscopes has been very effective. And we needed also to, together with other colleagues, to develop instruments to work where we could see, to reach the point allowed by the working angle of the approach, and to work properly on the target. One of our friends that has been already quoted, Dan Kelly, Dr. Laws, always uses the microdoppler probe, because we know that the carotid both are on the lateral aspects of the approach. So it's important to check the position of the carotid arteries. And also other instruments, the bipolar forceps are very useful. So all of us have tried to do better. And the surgical technique is important, but Dr. Laws has told us that what's important is the method we use to approach what we are doing. And so I think that besides who has been the first, the second, the third, it's not important, but Dr. Carrao has been crucial in the development of this approach through the endoscope, because he was a very good expert of the anatomy. And so first worked with this Dr. Joe, then with Dr. Cassan, but has been crucial. And these are the Italian friends. And for me, Dr. De Divizis was the teacher with whom we have worked together to perform what we have divided in 3 steps: nasal, sphenoidal, and cellular steps. In an anatomy that we didn't knew exactly, and now we always try to identify most landmarks, surgical landmarks along the approach. First, we lateralize the middle turbinate, then we remove a posterior part of the nasal septum, And we see here already, quite often, we see the cellular floor, but we have to be able to work properly on the target. And this is the posterior aspect of the sphenoid. You see the cellular floor in the middle with the carotid and optic protuberances laterally, between them the optocarotid recess, below the clival, and the upper part of the planum sphenoidale. And this is another image from the anatomical dissection. And this is a video clip where, you know, what has been important. We had a contribute from our ENT colleagues, but we gave them a very important concept, the possibility, the need to work with two hands. That's the microsurgical attitude we learned from our teachers, and we have not changed in our work. You see, this is a microadenoma. You see on the left the bulging of the carotid artery. And we use this approach for non-functioning pituitary tumors. We use for CTH secreting tumors. We do use for GH tumors, secreting tumors, together with drugs that combined with the approach give the patient a good life. And also prolactinomas. In the first instance, we thought that the drugs bromocriptine and then carbergolin took our work aside, but it was not like this, because 15% of these patients do not respond to medical treatment. Sometimes there is a chiasmatic compression that needs immediate relief, and in other conditions we have a pituitary apoplexy with chiasmal offense, and also sometimes with the oculomotor nerve compromission. So we need to perform our surgery. And the therapeutic goals are the ones we can see here: the relief of the mass effect, normalization of the hormonal hypersecretion if present, if possible, the restoration of normal pituitary function with preventing the recurrence of the tumor. And we always give tissue for molecular studies, which is in some instances are going to replace our work. The best results are with microadenomas. In the other conditions, we need to complement our work. But moving to the extended approaches that I am going to in some way to speak, we understood in 2002 that there were great possibilities of the approach, that we were not anymore working on the cella, but there was a world around the cella. And Gabrizzada made this title, Raising the Bar, because it's some way what happened with the jump, that this kind of work that's not different from the ventral jump changed the possibility of going higher than before and expanding the horizons, because there was a world around the cella, above the cella, below the cella, in the viral area, up to C2. And laterally to the cella, we have been speaking about cavernous sinus invasion. And so also the indications about different pathologies have greatly extended. And I will try to shortly show what I have written here. There are different models in different anatomical districts. And if we go above in the tuberculum cell planum sphenoidalis area, you see here that the area of bone you are going to remove starts from the, I would say, from the upper or the middle of the cella going above. And also the area of the tuberculum cell that's seen differently from below. It's a notch. We named it supracellular notch. Gives different possibilities of approaching the pathology we find inside, according to a different sphenoid sinus configuration, which gives a working area. You see, very good in some instances, very bad in other instances. If you see the image on the right for meningioma, there is a long tail in both directions. So you have to consider this, including the shape of the sphenoid sinus. And there is we studied these anatomical triangles and quadrilaterals, and to know exactly what we are having behind the approach, considering that we do not have to cross the nerves. Otherwise, there is a sort of paralysis. You can work on the nerves, but always by manual dissection, and knowing that these tiny small vessels, perforators, sometimes can give bad surprises, coming from above, coming from below. There is no difference, but we need to know, as Dr. Loz said, we have to remember after surgery, the sodium and potassium concentrations and water input, and we might have bad surprises if we don't take care of these vessels. And if we don't remember exactly the biology of the lesions, it's useless to go inside the cavernous sinus and to do artificial works if the biology doesn't support our kind of work. Our series is nothing as compared with the work of Dr. Loz and the giants before me. So, but it's a good experience, and it's a good experience because many people were laughing at our work in the former times. So it's always important to have seen what was happening after the first moments. And going to the extended approaches, we can speak of adenomas and other entities. It's important to say that's not important, the dimension of the adenoma. Giant adenomas can be safely afforded by this way, but what is important are the relationship of the adenoma with the surrounding structures. I will show you one or two cases. You see this pituitary adenoma, and you always see two instruments in the cella. A microsurgical attitude is confirmed as if we were working from above. And now, after the cellar removal, we extended the approach above, and you see that we could find some sort of capsule above the adenoma. So it's a gentle work of with the two ends of traction and counter traction, and this is the result after surgery with the complete removal of the tumor. And this is another case. We had a very clear, consistent capsule of the tumor, and you see here that we could dissect the tumor from the pituitary, leaving aside the pituitary stalk with by manual dissection, and you see suction and elevator, and you will confirm at the end of this video. You will see the postoperative control that's real satisfactory. You see in which condition the optic nerve was before surgery, and this is the image after surgery with the pituitary stalk and the pituitary gland. But in our experience, craniopharyngiomas, which is a very difficult tumor, and as Harvey Cushing said, the most forbidding of intracranial tumors, is giving us the best satisfactions. It was not considered to be amenable to this kind of surgery by giants of neurosurgery. But even Chirich, for me, has been very inspiring. His presentation in 1979 at the CNS, where he gave a very good lesson about the anatomy of the anatomical relationship of the craniopharyngioma with the arachnoid endothelium, which also Spanish group is now Prieto and Pascual. Yeah, they are studying properly recently. And we think that considering our experience, this is a series of our conjoined group together with the Bologna group, but also an international consensus that we've made in 2019 about craniopharyngiomas. I think that today can be considered in most of the cases the preferred way of approach. The craniopharyngioma is a benign tumor, but with local aggressiveness, extremely variable in the pattern of growth, and a behavior that's some way unpredictable. For years to stay quiet and then starts again. So we need to obtain a total removal of the tumor, but we have to balance between total removal and possibility of damaging the patients. So we need to consider the tumor topography, the adherence to the structures, the size and the consistency. And today we could say that also the a prefixed chiasm, it's not an absolute contraindication for an extended approach. And which it's important to know the position of the stalk, of the pituitary stalk. And also what to do with the pituitary stalk in order to prevent the recurrence. We have used frequently also in craniopharyngiomas involving the third ventricle, as you can see in this case. And I am going to show one of our cases where you can realize that with the removing the craniopharyngiomas, you obtain step by step the possibility to proceed along the surgery. Start the first steps that give the possibility, together with the technology you see here, the cavitron that helps in having a first piecemeal removal, and then with the great patience and not striving on the same point, but also being able to move to another side of the tumor and then to go back to the former trouble, with respecting obsessively the floor of the third ventricle. This has been our main issue. And you see here in the ventricular craniopharyngiomas, in our series, we have made standard and extended procedures. Standard procedures were done also in former years quite often by experienced surgeons, but now we have done almost 100 cases of extended approaches. And we consider that also the Achilles heel of the approach that was CSF link has been is not anymore a problem, because we reconstruct with the flap, with the fat, with the nasoseptal flap. And another small trick that the day after surgery we have the patient leaving the bed. We are not, this is what we do, and I will show you with a video clip, but just the fat as a cork, as a cork inside the approach. You see where the letter B is here, half inside and half outside, and then the nasoseptal flap. I will show you no anymore multilayer reconstruction, no anymore gasket seal closure, no anymore sphenoidal balloon. And here it should be the, the image of the closure. You see here the chiasm. We put the fat half inside and half outside the hole we are made. Some just a few drops of fibrin glue, and then the nasoseptal flap. The nasoseptal flap we used to harvest just at the end, at the last minute, and small sponges inside, and this is the closure. Then the day after, you see small sponges, and the day after surgery, we made a CT scan to see the amount of air that has entered the skull. But if we change the position of the bed of the patient, now we are able to have much less air than before, because in former cases we had a sort of pneumocephalus. Where we are moving, it's hard to say, courtesy of another great mentor, Dr. A, Dr. Apuzzo. I don't know. I'm not able to tell you. I tell you that we are now studying together with the pathologist and the neuroradiologist the possibility to understand even the molecular subtypes of some pathologies in order to know before what is the need to, which way to be aggressive or less aggressive, to know as many more possibilities in advance, because the teamwork and the great leaders, as we have been lucky to have, permits us to be very positive concerning our future. Thank you very much.
Thank you very much, Professor Cappabianca, for this wonderful talk. I think there are many issues and probably many questions. Maybe is there any question from the other moderator or panelists of the speakers?
Miguel, may I?
Sure, please.
Thank you, Prof. Cappabianca. That was a wonderful talk. And also thank you for all the work. I remember all the beautiful books with all the illustrations and high quality pictures. I have a question about one of the things you mentioned in the talk about the extracapsular resection of non-functioning pituitary tumor. Is it something which you decide in advance, or you decide on table whether to go extracapular for such tumors?
No. We decide during surgery.